Obviously, liver docs can't do it all. There's not enough liver docs in this country. This really does need to be a kind of a circle the wagons and everybody jump on board. Certainly all the primary care folks, so family medicine, primary care, internist, excuse me, probably OBGYN as well. And then certainly the gastroenterologist need to know about it. The endocrinologist should be in tune with this. Turns out that if you look at diabetics, about 80% will have fatty liver, 70 to 80%, and about 30 to 40% will have NASH, the more progressive form of the disease. And actually of that group, about 40% will have advanced fibrosis at the time we diagnose them. So if you're looking for an enriched cohort of patients, it's actually the diabetics. So the endocrinologist should really be keyed in on this. I think what's helped the most, honestly, is pharma, big pharma. They were focused on hepatitis C for the past 10 years. And now that we've pretty much found a cure for 95+% of hepatitis C patients, what I call that Lord of the Rings eyeball has shifted to the next big thing. The next big thing happens to be a disease that's 6 to 7, 8 times more common than hepatitis C in our country. And without any FDA-approved therapy, there's a tremendous opportunity for these pharmaceutical companies, both small and huge. So you see startup companies jumping in, you see the big Mercks, the BMSs, the Gileads, all starting to focus in on fatty liver as well. And as part of that process, we have to recruit patients for the clinical trials. That in and of itself requires disease state awareness to the gastroenterologist to say, hey, you got to biopsy these people. Then I get pushback from gastroenterologists at times, and they say, well, there's no FDA-approved treatment, so don't we just tell them to lose weight and exercise? Well, yes, that's still the mainstay of treatment. In fact, data would suggest that 10% weight loss is where you begin to see resolution of NASH and improvement in fibrosis. Got it. Nice study recently done, large numbers of people, prospective, 1-year follow-up, weight loss recommendations, diet and exercise, found that 66% of patients didn't lose a pound, they didn't gain a pound. 20% gained 10% body weight actually over the course of a year, and 20% lost somewhere between 5 and 10% of their body weight. How many reached that target of 10%? 6.9% of the patients. So what that means is we can talk all day long about losing weight and exercise, but the vast majority of our patients will attempt it. They'll fall off the wagon and not reach their weight loss goals. So the disease is continuing to progress, so now we have to look at pharmacologic therapy to halt the disease. That's kind of where we are now, but the gastroenterologists don't understand that biopsy is actually required to make a diagnosis of NASH. It's actually in our practice guidelines. So we have to have that discussion with them that how can you relate to your patients when they say, Doc, how bad is it, if you don't do a liver biopsy? And the analogy would be doing a colonoscopy, finding a mass in the colon, taking a picture of it, and not biopsying it, and then talking to the patient after the procedure is over and they're awake saying, yes ma'am, we've found a mass in your colon. Oh, really? Well, how bad is it? I'm not sure. I just took a picture of it. I didn't biopsy it. We'd have to go back and biopsy that and maybe take a CT scan of your colon to see if there's a metastatic disease. You would never do that, right? Same thing with liver. You have a fatty liver, and they have risk factors for NASH, and those risk factors are really several. So age over 50, postmenopausal female, Hispanic ethnicity, BMI greater than or equal to 30, a rising ALT and AST, or an AST to ALT ratio greater than 1, all those are independent predictors of NASH. So if you have a patient sitting in your clinic with metabolic syndrome, obese, over the age of 50, particularly if they're female and Hispanic, their pretest probability for NASH is really, really high, particularly even if you throw in diabetes alone. That patient should definitely get a biopsy because they're at the greatest risk for disease. And then you can have a real discussion with them about natural history. Because here's the kicker. If they don't have NASH, their risk of progressing to cirrhosis and end-stage liver disease is very, very little, very minimal. Alternatively, if they have NASH with any degree of fibrosis, the rate of progression is actually, in one study, 1 stage per 7 years, as quickly as that. So to have that intelligent discussion, you have to have a biopsy. I don't think everybody needs a biopsy, but I think if you have risk factors for NASH, the more you have, the higher the likelihood that you do have NASH.